हाँ, काइंडली बता दें मेरी आवाज़ क्लियर आ रही है और आपको स्क्रीन विजिबल है। चलें ठीक है। अच्छा, थोड़ी देर वेट कर लेते हैं। अम, ताकि अगर और किसी ने आना है तो हमें ज्वाइन कर लें, फिर इंशाल्लाह स्टार्ट करेंगे। अच्छा, काइंडली ये बता दें कि डॉक्टर ताबीर हैं, डॉक्टर जकाउल्ला हैं, डॉक्टर जरियान शाह हैं। तो बस काइंडली ये बता दें कि आप अभी क्या कर रहे हैं, मतलब कौन सी स्टेज में हैं, हाउस ऑफिसर हैं, पीडियाट्रिक ट्रेनी हैं या मेडिकल ऑफिसर हैं, ताकि थोड़ा आइडिया हो जाए। ओके। अच्छा चलें ठीक है, स्टार्ट करते हैं। काइंडली ये बता दें किसी को अगर मतलब अगर उर्दू वगैरह से उसको समझ नहीं आती या कोई इशू है तो वी कैन आल्सो स्टार्ट द लेक्चर इन इंग्लिश, देयर इज नो प्रॉब्लम। सो काइंडली गिव योर सजेशन। बस एक दो मिनट है, देन वी विल स्टार्ट द लेक्चर। And if you have any question, please write in the comment section, and then we will discuss the question at the end of the lecture. Okay, we are going to start the lecture. My name is Dr. Zeeshan. I have done MRCPCH Part 1 and 2, and I have been in the pediatrics department for the past 5 years, uh, working as a medical officer. And today I am here in the Doctor's Place Academy to give lecture on epiglottitis in children. Uh, Doctor's Place Academy, as you might have known already, that brings a lot of good courses. I have also done like ECG and medicine courses from Doctor's Place Academy. So it's a good start for the new doctors and also uh, who lack in different disciplines. So let's start the lecture. And I think my voice is clear and you can also see the slides. So today's topic is epiglottitis in children. So epiglottitis, one thing you have to remember that it's an emergency. So kindly don't take it lightly and just remember that it's an emergency. So you have to be quick, but don't panic. That's number one, if you want to manage this patient correctly. I don't know why the slides are not moving. No, yeah. So in this lecture, we are going to discuss the definition, etiology, sign and symptoms, diagnosis, like the investigations, differential diagnosis, and the treatment plan. So the definition, epiglottitis, it's the swelling and inflammation of the epiglottis and the surrounding structures, epiglottic folds, and retinite cartilages. Okay, so let me show you. So this is the epiglottis, as you can see, and I want you to remember this picture because this will also help in the diagnosis of epiglottitis. So this flap, as you can see, is epiglottis, and the main function of epiglottis is to uh, close the airway during swallowing so that the food or the water does not get into the air. That's the main function of epiglottis. In this picture, as you can see, the epiglottis is covering the airway and the food is going into the esophagus. Okay, so this is epiglottis. This is the posterior view of larynx. So this is epiglottis. Yes, this is epiglottis. These green lines, these lines present the epiglottic fold, and this is retinite cartilage. Okay, so these three things, they make the structure which gets inflamed during epiglottitis. Okay, so back to the second slide. This is normal uh, picture of epiglottis, this C shape or U shape, you can say. Structure is epiglottis. These are vocal cords, okay, and these are epiglottic folds, and this is retinite cartilage, okay. And in the picture B, you can clearly see the inflammation of epiglottis, and it's too much inflammation. You can clearly see there is an opening, and you can see vocal cords, but here there is narrowing of the airway. So you can imagine like it is an emergency. And one thing that you have to remember, it's an emergency, and also don't examine the patient. Please, if you can't take anything from this lecture, just remember it's an emergency, and don't examine the patient. Okay, because any slight agitation might lead to closure or blockage of the airway, and the child might go into the respiratory arrest. So uh, don't examine the patient. So what's the etiology? Its most common presentation is between the 2 year and 2nd year of age, mostly in an unvaccinated child. So in history, the prominent thing that you are going to ask is whether the child is vaccinated or not. If the child is unvaccinated, then your most probable diagnosis would be epiglottitis. And we will also discuss the differential diagnosis further down the line. Okay, so the most common cause is Haemophilus influenza type B. It's a bacteria. It's not a virus. So you also have to remember that. Epiglottitis also occurs in the adults, but the picture is not as severe as it is in the children. So in adults, it's caused by Haemophilus influenza type B, also some species of Staphylococcus and Streptococcus. The 4 Ds of epiglottitis: dysphagia, dysphonia, drooling, and distress. The dysphagia is because the epiglottis is too much inflamed, so the child is unable to swallow due to the pain. When there is dysphagia, then the child is not able to swallow like saliva, so there will be drooling, and there will be dysphonia because the child does not want to talk, because uh, anything that irritates the larynx or upper airway is very painful for the child. So there will be dysphagia, dysphonia, drooling, and the child will be in distress. There will be a clear toxic look of the child. Okay. Like whenever you see a patient that comes into the emergency, and when you see the patient, you will immediately think that this child is not stable. This child is having some sort of uh, an emergency. Okay. So signs will be toxic, very ill-looking child, acute onset of fever within hours. That is very important to remember, because this thing will differentiate epiglottitis from another disease which we will discuss later. Okay. There will be tachycardia, tripod position, a common term used while discussing epiglottitis. It's simply that the child will be sitting in a tripod position, like the child will be leaning forward and slightly neck extended to keep the airway as much open as he or she can. Okay, so this is a classic tripod position. So there will be history of sore throat, absence of cough. So the child will be able to cough, but the child will not cough because of the pain, and also the compromise of the airway. So the child will not cough, so there will be absence of cough, restlessness, and anxiety. So how we will diagnose epiglottitis? So the gold standard is indirect laryngoscopy or flexible fiber optic laryngoscopy. But as I mentioned in the start, please don't examine the patient. So examination should only be done in an ICU setting, or the setting where you can immediately manage the airway. Okay, so these are the findings: a cherry red epiglottis, pooled saliva, inflammation, and edema of supraglottic structures. I hope I'm not blocking the screen. So the diagnosis is most often by the X-ray, and I remember when we were studying uh, epiglottitis, so we studied, like, we see a thumb sign in the X-ray, but we will not uh, find any thumb sign in the X-ray. So this is the normal picture. This a thin fold is epiglottis, as you can appreciate that, and this is the thumb sign. You can also uh, remember this by placing your thumb on the slide, and if you can do that, you will remember this forever, I think. So this is a thumb sign. This presents the inflammation of the epiglottis. This is the lateral uh, view of neck. Okay. So this is the differential diagnosis, CROP, or laryngotracheal bronchitis. The main thing that you have to remember, is that the child who presents with epiglottitis will be a toxic child. Like the clinical presentation of the child will be toxic. You will immediately know that this child immediately needs an intervention. While the child who presents with croak, uh, it will be a stable child, and there will be a history of 2 to 3 days of sore throat and cough. So you can also differentiate from that. As we already know that in epiglottitis, there will be a very short history of fever, like within hours. Okay. Also, there is a classic cough in crow, which is called barking cough. Like there will be a typical sound will be produced when a child coughs. The child will be able to swallow. There will be usually mild to moderate stridor as well. Okay. So uh, the investigations will be done after the stabilization of the child. You have to remember that, please, whenever the child comes and you suspect epiglottitis, don't poke the child, don't do anything to the child. Make the child comfortable as much as you can. Okay. So when the airway is secured, then you can go for taking the blood cultures and epiglottic swab if the child is intubated. Okay, you can also go for PCR for Haemophilus influenza type B if available in your settings. So the main topic in epiglottitis was to discuss the treatment. So always follow the ABCDE protocol in any emergency. And as I have mentioned, epiglottitis is an emergency. So kindly follow the ABCDE protocol. So the initial step is to avoid throat examination or agitation of the child. Okay, keep the child in a position of comfort and alert airway team immediately. In that team, there will be anesthesiologist or any ENT member who can easily do the intubation if needed. First, we will secure the airway. Endotracheal intubation is a gold standard. It should be done by anesthesiologist in OR or ICU. Emergency tracheostomy is sometimes needed, but if the child presents early, then it can be avoided. Extubation is done after 24 to 72 hours, only if the swelling resolves. So the medical treatment, we will give this supportive care, IV fluids, isotonic fluids. You can use normal saline 0.9% at 20 to 30 ml per kg as the child is dehydrated, and also as the child is nail purple. Okay, you can also use antipyretics, injection paracetamol 10 to 15 milligrams per kg per dose twice a day or thrice a day, depending upon the condition of the child. And don't forget injection dexamethasone 0.6 mg per kg given once. But in some hospitals, dexamethasone is given for first 3 days, once a day. So it depends upon your hospital protocol. So for antibiotics, we can go for ceftriaxone, 50 to 75 milligrams per kg per day, IV OD, and it should not be given in ringer lactate. Please remember this. Because recent studies show that ceftriaxone gets precipitated in ringer lactate solution. So it should be given in normal saline. We can also use cefotaxime 150 to 200 milligrams per kg per day, and it should be divided into 3 to 4 dosages. If there is a suspected case of methicillin resistance Staph aureus, we can also add vancomycin along with ceftriaxone or cefotaxime. I hope I'm not going too fast. So the duration of the treatment is 7 to 10 days, depending upon the condition of the child. If the child gets better in the first 3 days, we can switch the IV antibiotics to oral. And for oral, we have best option of amoxicillin and clavulanate acid. So we can give augmentin uh, depending upon the condition of the child. But first 3 days we have to give IV antibiotics. Uh, Prophylaxis and immunization. Uh, any household contact should be given prophylaxis. Uh, For children, it's rifampicin 20 mg per kg per day. Maximum is 600 mg once a day for 4 days. And for adults, it's 600 mg once a day for 4 days. The Haemophilus influenza type B vaccination schedule is second month of birth, 4th month, 6th month, and 12th to 15th month. You can give at 12 months or at 15 months of age. And after the vaccination, like I don't know the exact numbers, but after the vaccination, the cases of epiglottitis were massively decreased. But still, in here, like in the developing countries, still we are seeing epiglottitis cases because of the uh, um, uh, because the children don't get vaccinated uh, properly. And when you see in the government setting, uh, when you see the card of vaccination card, there are a lot of dosages that are missed. So I think we have to educate the parents on the importance of vaccination. So the summary is it's an emergency. So uh, secure the airway, avoid the examination, start antibiotics, broad spectrum antibiotics, and supportive care. If the child is intubated, then we can go for extubation depending upon the condition of the child. And we will also give the prophylaxis. And the other thing is to educate the families about the vaccination of Haemophilus influenza type B. Take home points are always prioritize airway, secure the airway, avoid unnecessary examination, and start empiric antibiotics early uh, because it's an emergency, so treat it as an emergency. And vaccination is very important for the prevention of Haemophilus influenza type B infection. Thank you, and don't forget to revise. So I selected this topic because it was a very small topic, and uh, I have seen uh, the cases very often in the government hospital setting, and there like sometimes there is a panic when they see a child like this. And I would also like to share a story um, in just a minute. Like I in my neighbors, I the mother came and she said that the child is uh, got fever and the child is drooling, like the saliva is coming out. And at that time, I was in final year medical student, but I was in the pediatric rotation. So I immediately diagnosed, like I suspected that this could be, I think, epiglottis because I think studied that a few days back. So they took the child to the emergency, and the child was well in like 4 days. So it's very important to immediately diagnose the case. And I hope you might have learned something today. If you have any questions, please do ask. And I hope you have learned something today. Okay, if you don't have the question, then I'm going to end the lecture. Dr. Sumaya, thank you. Thank you so much. You're welcome. And please revise this topic. It's very important. So, and always remember, don't examine the child. Okay, everybody. Uh, take good care of yourself, and please revise the topic. Thank you. Thank you. Take care. Allah Hafiz.